Hi, everyone. Welcome back to the Breast Cancer Podcast. Hello, I'm your host, Dr. Deepa Halaharvi, a fellowship trained breast surgeon, and also happen to be a breast cancer survivor, thriver, and a warrior, living my best life. As you know, breast cancer affects millions worldwide, touching lives in a profound ways. Whether you're someone facing a diagnosis or a supporter seeking information or just eager to learn more, this podcast aims to be a beacon of understanding, hope, and empowerment. I'm here to talk about all things breast cancer, from surgery to survivorship, as well as high risk for breast cancer to metastatic breast cancer. My goal is to provide you with reliable information, share inspiring narratives, and foster a supportive community. I know firsthand the challenges breast cancer diagnosis brings. Throughout this podcast, I will give you strategies to handle difficulties that arise from cancer diagnosis. We'll have insightful conversations with medical experts, researchers, survivors, caregivers, and advocates. I will tackle topics that impact our lives as cancer survivors. My goal is to educate you and empower you to live your best life. I definitely have. Well, let's get started. Hi, everyone. Welcome back to the Breast Cancer Podcast and the Breast Podcast Ever. I have the famous Dr. Tiwari with me here today. And we're doing a lot of education today, which I always get excited about. One of the common questions I get asked is, what is a nipple sparing mastectomy? And we perform a lot of surgeries together. As a breast surgeon, I remove the breast tissue. So I always explain breast as a pillow in a pillowcase. It's easy to conceptually visualize it. And I remove the pillow, and he uses the pillowcase to perform reconstruction. So, what are different types of mastectomies? Well, there's a skin sparing mastectomy where we remove the skin, where we remove the breast tissue and the nipple. And so they just have this pocket of skin for which then Dr. Tiwari does the reconstruction, whether it's using tissue expander based reconstruction with implants down the road, or in autologous reconstruction, meaning using their own body tissue. Most commonly is the deep flap. And there is a nipple sparing mastectomy. And what that is where I remove the breast tissue, so the pillow and the pillowcases, which is the skin, including the nipple and the areola, is intact. We tend to make incisions at the bra line, at the what we call the inframammary fold or the bra line. Sometimes the incisions are on the side, and Dr. Tiwari and his team, you do perform the reconstruction. And who are candidates for nipple sparing mastectomy? You may want to know. This is typically for those women who are kind of a thin body habitus and have like a B to a C cup breast size, not too much drooping, or we call ptosis, which is drooping. As women, when we have babies, the breast tend to, kind of droop a little bit. So not too much drooping. Women who are not smokers, I think that's a big thing.
Yeah.
Anytime we perform reconstruction or, surgery, we worry about infection and things like that. And so for women who are, fairly thin, body habitus, I say, usually BMI of 30 or less, and non-smokers and have not too large of a breast are really great candidates for nipple sparing mastectomy. Would you add anything else to that?
Yeah, I think that's very good information. I think we've seen some of the indications broaden with the use of nipple delay procedures. So, what is a nipple delay? Well, a delay is a technique that's been used for a very long time in plastic surgery. And the way I like to think about it is it's a way to train the tissue to live on a more limited blood supply. So, how does that relate to a mastectomy? Well, when Dr. Halaharvi does the nipple sparing mastectomy, what we always worry about is the nipple going to survive? Is the nipple going to live? Well, how can you increase the chances that the nipple is going to survive? You train it to live on a more limited blood supply. So about a week or 10 days prior from the mastectomy, where we'll be working together, Dr. Halaharvi will take the patient back to the operating room, make an incision, the same type of incision that we'll ultimately use for the mastectomy, but lift up the nipple complex and essentially put it back down.
Yeah.
And you're now having the nipple complex on a more limited blood supply because you removed some of the connections
Mhm.
to the breast tissue. And what happens is there are vessels in the skin that essentially dilate over time and increase the likelihood that the nipple will survive. So we're less worried about it after the mastectomy. So nipple delay has definitely broadened the indications for nipple sparing mastectomy. as well as decrease the risk in nipple necrosis or those types of problems, which is the main thing that we worry about for
Yeah.
nipple sparing mastectomy.
Yeah, for sure. I talk to, women about nipple necrosis or losing blood supply to the nipple infection. I tend to tell people nipple is sort of like a dirty structure. It does have those ducts and, coming out, and it can cause the higher risk of infection if you're performing a nipple sparing mastectomy. And so, for those women who want a nipple sparing mastectomy, meaning they want to preserve the nipple areolar complex, large breast, not really a great candidate for nipple sparing mastectomy. Nipple delay procedure, Dr. Tiwari and his partner, Dr. Kali, have brought this into town, which has been a great addition to our practice. We are performing nipple sparing mastectomies on women with larger breasts because of nipple delay procedure. And like he explained it so well, it's performed about 2 weeks before the mastectomy, where I make the incision very similar to the incision I would be making for the mastectomy. And I remove the breast tissue from underneath the nipple. So nipple has is very highly vascular structure. It has blood supply not just from the breast tissue, but also from the skin flaps. We have blood vessels that's coming from a blood vessel called internal mammary, the perforators from that. There is blood vessels coming from the axillary artery that, it goes up underneath the collarbone. And so when you remove the breast tissue from underneath the nipple, it forces the skin to increase the blood supply to the nipple. So when we go back 2 weeks after this procedure, there's increased likelihood of nipple not dying. And this has been a really great addition. And we definitely use it for those women who are slightly on the larger side, have larger breasts, have had surgery in the past on their around their breasts. It definitely definitely does increase the chance of preserving the nipple. But there's always that risk of losing the nipple and infection and things like that. And
Yeah, one thing I want to definitely shout out Dr. Kale because he was the one that
yes,
really
yeah,
pushed us into this. So thank you, Dr. Kale.
yes,
The other piece that I really like is the fact that you can 2 weeks prior do a sentinel node
yes, yes,
evaluation
yeah.
on patients. So we have that information, we have
Yeah.
that data. So when it comes to the time of the mastectomy or reconstruction, we know whether the sentinel node is positive. We know whether the patient will need axial lymph node dissection. It takes away that question mark that we used to have before this type of an approach.
Yeah, no, 100%. I actually love that myself. Also, if someone who's had a positive lymph node, they get chemotherapy and then you're doing surgery, it's important for me to know going into surgery whether this lymph node is still positive. So, to perform a sentinel lymph node biopsy, checking those lymph nodes, the one that was positive before, as well as, a few other first draining lymph nodes, sending that out pathology, gives us enough time to get that information back. So if there is cancer in the lymph nodes, we go back a couple of weeks later when we perform the mastectomy, I can perform the lymph node dissection. So this is really great for that reason as well. Um, you know, People ask what makes a good plastic breast surgery team. And I think I work with a number of plastic surgeons. And the thing that happens behind the scenes, a lot of people don't know, is we talk a lot behind the scenes. We communicate a lot about the patients. We take a lot of factors into account as to what type of surgery is good for this patient based on their age, their body habitus, the type of cancer.
Yeah.
I also have to say for nipple sparing mastectomy, we want the cancer to be away from the nipple. Patients who have cancer close to the nipple are not candidates for the nipple sparing mastectomy or
Is it
involving the
still
nipple.
is it still about a 3 centimeter?
We used to say 2 centimeters,
3 centimeters?
and now we say a centimeter. But the thing about the nipple delay procedure is we remove the breast tissue underneath the nipple and send that sent to pathology. So if there is cancer in that tissue, then they are not candidates for nipple sparing mastectomy. So
Mm.
we can remove the nipple at the time of the mastectomy or down the road. So that gives us more information going into the surgery as well. And yeah, so in terms of, our jobs is we want to make sure we're doing the right thing for the patients. I often see when patients come in, they've just been told they have cancer, they're in a survival mode, they want the cancer out, they don't care what type of reconstruction, whether they want reconstruction, not reconstruction. What I can tell you from my own experience is people care on how they look like. They want to look good, at least in clothing, they want to look good. So even they may say they may not care at that time, but it's important for us to take the time to have that communication with the patients and have that shared decision making, meaning we give them the information as experts in the field and help them make the decision that's best for the patients. Do you agree
Yeah,
with that?
absolutely. We never want the reconstruction to get in the way of the cancer treatment. But as Dr. Halaharvi is pointing out, I think for many patients, there obviously is a cosmetic aesthetic component to what's happening with a breast cancer treatment. And I think that it's important for patients to know that that is taken very seriously, and it's taken very seriously. We do talk about these things all the time. And a lot of this is just shared decision making and having conversations with patients and understanding what's important to them. So I think that such a big part of what we do every day, and to be able to do it in a team environment is really important because the communication between surgeons, these are complicated issues, and the better your surgeons communicate, I think the better people's care is in general.
Yeah, absolutely. And it's our job to find out your goals and what you want, with your with the surgery. What are your goals? What are you wanting to accomplish, and how do you want to look like? And those are all the things that's important for us to have that discussion ahead of time. A breast cancer is never a medical or a surgical emergency. I mean, you have time to make those decisions. So it's not an emergency that you have to make a decision right then and there. I do have a question for you, Dr. Tiwari. I know, and we talked about that in the other podcast about prepectoral versus subpectoral implant.
Yeah.
What is your preference and why?
So now we do a lot of prepectoral reconstruction. This is an example of a tissue expander, and we have these tabs on them that allow us to very specifically position the tissue expanders. I think in general we've moved almost completely to prepectoral reconstruction. People have less pain. There's a better cosmetic result. There's less functional interruption to the pec muscle. There's a lower infection rate. So there's so many advantages to having the implant above the muscle. What we've been able to now do is use what's called an acellular dermal matrix to wrap the tissue expander. So it has opened up this whole possibility that wasn't really true maybe 5, even 7 years ago. We couldn't really do a lot of prepectoral reconstruction, but now that we can, it's definitely my favored
Yeah,
way to approach
I,
this.
I think women look amazing in the prepectoral approach myself. So,
And they also don't have the pain. I think
oh yeah,
the
absolutely,
pain
yes,
was a huge
yeah,
problem
yeah.
with submuscular
Yeah.
reconstruction.
Just imagine sitting this behind your muscle. I mean, that
Yeah,
just looks so
it's
painful.
it's
And
huge,
yeah,
and,
and it's a big thing.
I
So
remember, and even now, I think a lot of patients are very worried about tissue expanders because of they know their mom or their aunt or somebody had a submuscular tissue expander, and they associate that tissue expander with pain.
yeah,
And admittedly, it was very uncomfortable for patients below the muscle, but I think a lot of that has been replaced with
yeah,
it above the muscle. Not completely replaced, obviously, it's still surgery, there's still pain associated with it,
yeah,
but I think there's just an order of magnitude difference between prepectoral and submuscular from a
yeah,
pain standpoint.
yeah, I agree. I do have a question for you. Do you like direct implant approach?
Yeah, we don't do a lot of direct to implant reconstruction. I think for a few reasons. I'll tell you what my thoughts are. I'd love
Yeah,
to hear your
yeah.
thoughts. Again, tissue expanders have these little tabs on them, so we can very
Mhm.
specifically position the tissue expander. An implant does not have a tab associated with it. They're not made that way. So there's always the ability for implants to move around in the space. And I always think of the mastectomy, the footprint of the breast is larger than the footprint of an implant. With an implant, you want a nice hand and glove type placement. And if the footprint of the breast is larger than the implant, there's a lot of ability for the implant to move around. And I think ultimately it leads to not as nice a reconstruction if we can very, very predictably expand the space. Now, not everybody, there's certainly are patients that I think direct to implant works well in. I think smaller breasted patients with a fair amount of stretch to the skin. So we're not stretching the skin, we're relying on the patient's own skin elasticity. So the best patient for a direct implant reconstruction tends to be somebody who's relatively small breasted, but still has stretchy skin. Um, Uncommon to find those patients,
Yeah,
honestly.
yeah.
So in general, by and large, we're doing tissue expanders. But yeah, I'd love to hear your thoughts
Yeah.
on it.
So I think right after the mastectomy. So my job is to remove the cancer and depends on the flap thickness and every person is different. Depends on your body habitus. If you have any fat underneath the skin, that makes a good flap. If you don't have enough fat for those thin women, the flaps are really thin. So you're trying to put this direct implant underneath the thin flap. I just feel like it puts too much pressure underneath the skin, personally, especially if you performed a nipple sparing
Because you're
mastectomy.
worried about
Your
compression of, yeah.
compression, yeah, of the skin as well as the nipple. So I've had a few patients who wanted a direct implant, and like Dr. Tiwari said, I think there are those perfect candidates, but I haven't really found too many of them myself.
Yeah,
So,
and there are practices that do a lot of
right,
implant-based
right.
reconstruction. I think it certainly can be done, but you got to be very careful about the patients that you do them on. I think like anything else here, communication with the patient, examining, patients, and really coming up with a plan based on what their goals are, and what's safe from a breast cancer
Yeah.
standpoint. Ultimately, that's the goal.
Yeah. Yeah, our goal is to remove cancer, but we also want to make you look good. So, and shared decision making, communication, telling us your goals. If you're not listening to, making sure, if you're not listening to you, making sure setting us down and listen to you. We want to listen to you. We want to do the right thing for you. Shared decision making, and again, it's never a surgical emergency. We can take time and figure out what is the best thing for you. So, thank you so much, Dr. Tiwari.
Thank
This has
you.
been great conversation on nipple sparing mastectomy, nipple delay procedure, as well as direct implant and prepectoral reconstruction. I hope our audience find this to be useful, and follow us for more. The best podcast ever, the breast cancer podcast, and give us a 5-star rating if you like this episode, and share it with your family and friends.
Thank you.
Until next time, bye-bye.
Bye-bye.
Thank you, everyone, for tuning into the Breast Cancer Podcast. Remember, you're not alone in this fight. I encourage you to be an active part of this podcast. Please share your stories, questions, and suggestions for future topics at my website called drdeepahalaharvi.com. And please share this podcast with others, especially if you found it useful. And please also give it a 5-star rating, if you will. Stay connected as we navigate the complexities of breast cancer. Until next time, take care and keep shining brightly. Disclaimer: this podcast is not intended for complete medical advice.